So the most common cause of gross hematuria is IgA nephropathy. And the most common cause of chronic glomerular disease is chronic glomerulonephritis. So here I just opened the symptoms in IgA nephropathy is cola or tea colored urine caused by blood. That means if the urine is cola or tea colored, it means that it should be a gross hematuria. Blood that can be seen in the urine. Foamy urine from protein leaking into urine. You can have foamy from protein, but the main thing you see is the cola or tea colored urine or blood in urine. Pain on one or both sides of the kidney, both sides of back below the ribs, swelling in hands and feet called edema, high blood pressure, weakness and tiredness. So if the question comes like what is the cause of gross hematuria in children, one of the cause you will choose is the most common cause is IgA nephropathy, and most common cause of glomerular disease is chronic glomerulonephritis. Next is child with diarrhea, then dehydration. So the child is dehydrated. There is flank mass and hematuria. All are glomerular causes of hematuria except what I don't know what E. coli he has written here. Maybe this is for HUS, maybe, I'm not sure. Child with diarrhea, then dehydration, flank mass and hematuria. Related to E. coli, maybe this is hemolytic uremic syndrome, but I'm not sure. Another question, this may be separate question. All are glomerular cause of hematuria except like IgA nephropathy, there is a glomerular cause. Chronic glomerulonephritis, there is a glomerular cause. But which is not a glomerular cause of hematuria is hypercalciuria. Hypercalciuria, the blood in urine, hematuria from hypercalciuria is not a glomerular disease. It's not a glomerular cause. Next is 2-month infant with generalized edema and oliguria was diagnosed congenital nephrotic syndrome. So NPHS1 is a gene related to this 1 minute. Congenital nephrotic syndrome, NPHS1, is a rare disease inherited by autosomal recessive trait. NPHS gene, NPHS1 gene mutated in NPHS1 children has recently been identified. The gene codes for nephrin, a cell surface protein of podocytes. So NPHS1, mutation in NPHS1 is the cause for congenital nephrotic syndrome, and it is inherited in the form of autosomal recessive trait, and this gene codes for nephrin, a cell surface protein for podocyte. Next, one of the following does not cause hypokalemia. Acute tubular necrosis. Acute tubular necrosis. We don't see hypokalemia in acute tubular necrosis. Why does acute tubular necrosis cause hypokalemia? These results suggest that, hyperkalemia. These results suggest that hyperkalemia that occurs in severe acute tubular necrosis stems at least in part of downregulation of the CHIF mRNA in the kidney, medulla, and papillae. The compensatory increase in colonic CHIF mRNA is not sufficient to maintain normal serum potassium levels. So, that means acute tubular necrosis will cause hyperkalemia, not hypokalemia. One of the reason may be whenever the cells gets break down, there will be release of the potassium which is present inside the cells, right? This can be one of the reason rather than what he is telling here. These results suggest hyperkalemia. Anyways, acute tubular, we have to remember that acute tubular necrosis causes hyperkalemia, not hypokalemia. How I can remember is whenever there is breakdown of cells, we know that the potassium is released into the bloodstream. Now there is a case scenario: bloody diarrhea, rash in lower limbs, hematuria, proteinuria, raised creatinine and urea. Raised creatinine and urea means kidney failure. There is proteinuria, there is hematuria, and there is bloody diarrhea. So this is HUS. Now there can be some confusion here. He's telling rash in or lower limbs. We all know that rash in lower limbs is a character of Henax-Schönlein purpura. Then why here the HUS is highlighted or ticked as the answer? HUS, the scenario starts with because here there is bloody diarrhea, increased blood urea and creatinine, that is kidney failure, features of acute kidney failure, disseminated intravascular coagulation may be the cause for hematuria, which DIC, which presents with purpuric rash all over the body. Usually it will be all over the body in HUS. It is not specified for the lower limbs. In HSP, why here they ticked HUS is they are explaining there is bloody diarrhea, starting with bloody diarrhea. There is hematuria, there is proteinuria, raised urea and creatinine, and rash. But the rash in HUS can be seen all over the body, and it will be purpuric rash due to disseminated intravascular coagulation. HSP, the scenario starts with in HSP, the scenario starts with colicky abdominal pain, purpuric rash in the lower extremities and buttocks. Secondary to intussusception, the baby may develop bloody diarrhea. It's not that these children will have definite bloody diarrhea. So you have to concentrate on the scenario and select the right answer here. Here the things going with the HUS is bloody diarrhea, raised urea and creatinine, then hematuria and proteinuria. But in the HSP scenario, what happens? There will be a purpuric rash, mainly in the lower limb and buttocks, and the bloody diarrhea is not seen. The bloody diarrhea. The bloody diarrhea is not seen mainly as the symptom here. It may be secondary to intussusception. It may develop. Okay. So the option here is HUS. Five-year-old child with nocturnal enuresis without day wetting. What to do? His 5-year-old child and there's nocturnal enuresis without wetting in the day. What to do? So reassurance. The answer is reassurance. No need to do anything. Maybe you can just encourage the child that if he doesn't pass, you will give him some stickers, some encouragement, things like this. But as such, it is reassurance. No need to start desmopressin at this time. And also no need to keep bed alarms. So 5-year-old child nocturnal enuresis, the first thing is reassurance and wait and watch. Maybe you can make some star charts if he spends the night without bedwetting. But as such, it is reassurance. No need to start desmopressin or bed alarm. Just we'll go through fast. What is the answer? here 5-year-old child without day wetting, what to do? Drink most of his or her liquids during the morning or early afternoon. Urinate regularly during the day, every 2 to 3 hours, or just before the bed, which is total of about 4 to 7 times a day. Urinate twice before bedtime, about half an hour apart, to fully empty the bladder. Allow the room for new urine. That means here, what we have to concentrate here is they have not suggested any medications at this point of time. You will only reassure and give some suggestions and maybe even star charts. But you are not going to start any medications, and also he has not marked for bed alarm also. Treatment of membranous glomerulonephritis. We all know that it will be pulse methylprednisolone with cyclophosphamide. Once remission, then we'll start with maintenance therapy with cyclophosphamide and alternate day steroid. So you will choose cyclophosphamide and steroid. And this is one more option for you. If you don't want to choose cyclophosphamide, the means the another option is chlorambucil. Okay. Worst prognosis renal tumor. Which is the renal tumor with worst prognosis is, we have options here: Wilms, renal cell cancer, clear cell sarcoma, and rhabdoid tumor. I think this is rhabdomyoma. Rhabdoid tumor, maybe what he has written is rhabdomyoma. You will choose here rhabdomyoma. Okay. Which is the worst prognosis renal tumor is the, let me check. So malignant rhabdoid tumor is a rare childhood tumor that commonly starts in kidneys, but also occurs in other soft tissues or brain. So the common site for this is the kidney, where it is referred to as atypical teratoid rhabdoid tumor. Atypical teratoid rhabdoid tumor. These tumors occur most commonly in infants and toddlers. The average age of diagnosis is 15 months old. So the worst prognosis in the renal tumors is the rhabdoid tumor. Okay, you have to remember this. This can come as a question. Next, a case of nephrotic syndrome presented with low sodium. What is the cause for low sodium? Decrease oncotic pressure. Okay. What is the cause for low sodium in a case of nephrotic syndrome is decreased oncotic pressure. This is why the oncotic pressure is decreased, because of decreased albumin. Okay. Okay, nephrotic syndrome presenting with low sodium. The reason is decreased oncotic pressure. What I understand is, whenever there is nephrotic syndrome, we all know that there is low albumin in blood vessels. So there's no good retention of fluids. Fluid is lost in the extracellular spaces. This is the reason for hyponatremia. Decreased oncotic pressure. Case diagnosed with IgA nephropathy. Next treatment. What is the treatment of IgA nephropathy? Is it a calcium channel blocker, diuretic, prednisolone, or cyclophosphamide? Prednisolone. The treatment for IgA nephropathy is prednisolone. So case diagnosed with IgA nephropathy, the treatment is prednisolone. Child with UTI on antibiotic. Vesico-ureteric reflex 3 and bilateral ureterocele. What is the treatment? Antibiotic. Okay. Child, he has UTI, definitely you have to give antibiotic. He is already on antibiotic. Okay. But the problem here is he has vesico-ureteric reflex 3 and bilateral ureterocele. That means if we draw he has this bilateral ureterocele, means big ureters like this, big ureters. So definitely if there is big ureters, what is the treatment? He's telling ureteral implantation. That means you will remove and you will put the good and new ureters. That is ureteral implantation and antibiotics. Just antibiotic will not do anything. Again, the process will recur again. De-roofing with ureteral implantation. He's telling ureteral implantation with antibiotics. So the treatment for ureterocele, the goal of surgery is to stop the ureter from ballooning and causing the blockage. There are several surgical methods your provider may use. That is transurethral puncture, ureteral implantation, upper pole nephrectomy. This transurethral puncture, this procedure involves puncturing the ureterocele. To do this, a surgeon inserts a cystoscope into the urethra and into the bladder. This procedure can be thought of as popping a balloon. It is usually an outpatient procedure, so there is no need for overnight hospital, but still uses general anesthesia. Ureteral reimplantation. This procedure involves the surgeon making an incision in the lower abdomen to reach the bladder. The surgeon then removes the ureterocele and reimplants the ureter into the bladder correctly. They also recreate the flap valve to prevent VUR. This surgery is generally more complex but successful in 90 to 95% of the time. So the option here is bilateral ureterocele. Your best option is ureteral reimplantation. Upper pole nephrectomy. This surgery happens when the upper part of the kidney isn't working due to damage from the ureterocele. This is most often for people with a ureterocele and a duplex kidney. But here the question for you, child with UTI on antibiotics, VUR, vesico-ureteric reflex 3 and bilateral ureterocele, the best option for you is the ureteral implantation and antibiotics. Post-streptococcal pharyngitis patient presents with RBC casts in urine analysis. To confirm this post-streptococcal glomerulonephritis with single test. Post-streptococcal pharyngitis patient, you will see RBC casts in urine analysis. To confirm this post-streptococcal glomerulonephritis with single test, I don't think normal complement goes in favor of post-streptococcal glomerulonephritis. Proteinuria can be seen in nephrotic and nephritic syndrome.
Look at something, something complement change.
Yeah, C3, it will be raised, right?
C3, yes.
Sorry, reduced or raised?
Raised. But yeah. not confirmed, but I think that.
I will check for you. Wait. But definitely there will be some change in the complement for sure. And this proteinuria can see in nephrotic also, but high blood pressure is one of the commonest factor in post-streptococcal glomerulonephritis.
I will ask you in question, ask single test. The high blood pressure recorded as a test or military. But high blood pressure.
Yeah, I don't know, because there is no high blood pressure. You are telling it's not a test, you mean?
Yes.
Yeah, I don't know, but
think
there is
في
no
monitoring.
options here, no?
Maybe يقول لك what the beside test we need. We will check random, we check yes blood pressure. But something some question ask the patient with acute asthma was the test. Some say oxygen, some say ABG. فكلمة test وinvestigation دي مهمة عشان الزول يقدر يفرز، لأنه أنا مثلا لو قريتها ممكن will answer proteinuria because it's test and the blood pressure is monitoring. What the best answer?
But the problem is proteinuria you can see in other conditions also, no?
But it's still a test, because sometimes if they say bedside tests, it's still a test. So blood pressure is also correct.
Yeah. See here, post-streptococcal glomerulonephritis is caused by prior infection with specific strains of group A streptococcus. Post-streptococcal glomerulonephritis is commonly characterized by significant C3 depression. That means C3 will be less and maintain C4 levels, especially in children. So we have to remember what will happen to complements in post-streptococcal glomerulonephritis is C3 will be less and the C4 will be maintained. See, sometimes the blood pressure is also considered as a test, as a bedside test. Glucose, blood pressure, urine dipstick, all those things. But what I feel that high blood pressure is more common in post-streptococcal glomerulonephritis than in nephrotic syndrome.
Yes.
Minimal change nephrotic syndrome, not necessarily that all children you see high blood pressure. But
Yeah.
yesterday also when we were reading, several times we read that there will be high blood pressure in post-streptococcal glomerulonephritis, most of the patients. So that is why he has chosen this. This is what I understand. Okay.
Okay.
Maybe there will be more options, but here among these three options, we will go with that. Girl with psoriasis have UTI. Treatment. Before also this question had come that there is a girl with psoriasis with UTI. Why they are telling prophylaxis, I don't know. He's telling prophylactic nitrofurantoin. We have to check, is there any connection here?
The psoriasis مش also affect the joint, also affect renal or no? As autoimmune. Well, I don't know.
That's what even I don't know.
I think psoriasis affects the kidneys.
Most of the autoimmune diseases, I think it can affect the kidneys as well. Can psoriasis cause UTI?
ده علاقة بالانترليوكين 17 inhibitor suggests that maybe cause specific IES. I don't know what IES.
I think for the psoriasis, yes, we have to treat any patient with UTI has to be treated. Once, what I understand is once the treatment is finished, they also need prophylaxis. This is what I understand, because this question was repeated before also. And here I think the question is incomplete. No question will be like this. In the exam, you'll have question with long scenarios. Okay. So what I understand is girl with psoriasis have UTI treatment. Actually, you will treat the UTI first. After treating the UTI, these patients need prophylactic nitrofurantoin to be continued. Why they need this, we have to check. We can check and find out for tomorrow. So that I will take a picture and keep this about this question, so that tomorrow when I'm free, I will try to check it. Because when the child has UTI, we don't start with prophylaxis. First, we have to treat the UTI, and then if at all they need, we have to continue with the prophylaxis. So there will be some change in the question there. At the moment, we'll keep like this. After the treatment of UTI in psoriasis, we need to start prophylaxis, and the drug of choice is nitrofurantoin. Why, what? Let's check and come back. 12 years old child with nephrotic syndrome. I think this came before also. If they ask you, if they give you the single choice, go with pulse methylprednisolone first. Usually they are combining methylprednisolone and cyclophosphamide for the remission. Then
Yes.
once the remission is finished, then for the maintenance, they give cyclophosphamide plus alternate day steroids. But
The previous question, can the patient with the nephrotic on steroid and not improve? The other option, cyclophosphamide. But just here, no say that, huh?
yeah.
No say steroid.
Yeah, but so the first preference will be methylprednisolone. If there is some other points like what we read yesterday, the other option is we have to add cyclophosphamide. But if they give you that they are steroid resistant, then you will go for cyclosporine.
Yes.
So all cause red urine, except, okay, beetroot, rifampicin, yes. Hypercalciuria, yes. Oh, what is this? Porphyros. Let's check what colored urine it causes, you know? If the meeting ends, I will restart, okay? Just